Hello and welcome to Berkshire Health Programs. I'm your host, Dr. Rebecca Caine. Our topic today is urology, and I'm here with one of our new urologists in town, Dr. Jason Ogiste. Thank you so much for joining us.
Yes, thank you for having me.
We'll be talking about some general urology, the common things that we see in practice. I would love if you would start us off just by introducing yourself and tell us how you came to be practicing here in the Berkshires.
Sure. No, thank you again for the opportunity. So I came on November 1st, but we were up here over the fall, October through into November, sort of moving in and getting sort of oriented to the place. And I started at Columbia. That's where I trained in New York City. Did my residency there, my fellowship, 5 years of that, and then went to Mount Sinai after that for another 10 years. So in terms of the transition of my employment, sort of about 10 years, and here I am now in the Berkshires. So it's been sort of a progressive moving out of the city and trying to find another place where life is a little more conducive to what it is my family and I are looking forward to doing.
So for those viewers who are not familiar with medical training and what it entails, could you explain kind of the sequence of the education and training?
Sure. So I trained for my medical school. I was at the University of Rochester School of Medicine Dentistry. Did 4 years of that. It was actually 5 years, but I did what's called a Howard Hughes Fellowship. It's a research fellowship for 1 year. That allowed me to go down to Cornell, do some research, basic science, and so on, and came back to Rochester, finished off at the 5th year. Between that 4th and 5th year is when we basically apply for residency. And I had no idea what I wanted to do yet. I sort of general idea that maybe it'll be surgery-based practice. I like general surgery. And my last rotation in my medical school at Rochester was urology. And I met Dr. Messing, who was the chairman there, and I got bitten by the urology bug, and it's sort of history from there. I applied and got in. My family base is in New York City, so I got in at Columbia. I had some other options too, but decided that for the family, really, it was probably best that we do something, back where the base, my brothers and my sisters, my nephews, my wife's family, and did 5 years there. 5 years of residency training, pretty rough, but that's residency. It's like the Army. You go through and you keep your head down and get the work done and take care of the patients and learn as much as you can so that you can sort of take the next step.
And you had a fellowship after that in female urology.
Correct.
So what made you decide to go in that direction?
Yeah, so it's one of those things. Urology is one of those type of surgical subspecialties that lends itself to going in a lot of different directions. You can do research, you can do general urology, you get a little bit of sort of general medicine, and then you can subspecialize. You can do stones, you can do oncology, cancer care, and benign disease, which is my area. So female urology and female pelvic reconstructive medicine is all part of that benign disease. So it deals with continence issues, pelvic organ prolapse like cystocele and so on, and just general bladder voiding issues, whether it be overactive bladder, frequency, things like that. So that sort of encompasses within that female urology sector that I wanted to focus on, and the bigger umbrella, benign disease. So on the male side, I do the BPH. I don't really do major oncology care, but I do enlarged prostate management. So that's on the men's side with urinary symptoms. Yeah.
So we are going to talk about each of these different areas one by one.
Yeah.
having you join the general urology group in the Berkshires really opens up the doors, because prior to you moving here, we didn't have somebody who specialized in any way in female urology, although all the urologists do practice. So remind us about your group that you've joined, and because there are several new doctors there now, right?
Yes, no, thank you for that. So Dr. Sinclair, Steve Sinclair, is our chief of urology, has done a phenomenal job in sort of reaching out to recruit back into the community young doctors who probably would be elsewhere, in major cities, on the coast, wherever, and are able to attract us to this part of the state, of the Commonwealth, and of the country. So we have Dr. Sam Litvin, who came right after me. He practiced, so he brings a ton of experience in the urology field. He's practiced for, I think, at least 2.5, 3 decades. Had a busy practice in New Jersey. Was recruited here by Dr. Sinclair. And his area of specialty interest is that of complex kidney stones. So Endo Urology is the term we use. And using special instrumentation and ultrasound and so on to actually break up complex stones in the kidneys that we probably couldn't manage otherwise by shock wave, lithotripsy, things like that. And he does general urology as well. So that's Dr. Sam Litvin. Dr. Aaron Brothers, he started about a month ago, trained at Walter Reed. And his area of subspecialty interest is that of the robotic oncologic management, so laparoscopic surgery, robotic-assisted surgery, prostate cancer would come onto that, kidney cancers would come onto that, certain reconstructive procedures of the kidney would come onto that. So that's his area, but he also does some general medicine, general urology as well. And I'm there, Dr. Caine, Kevin Caine, been with the practice for quite some years, and now he's focusing on Fairview. So all across the board, now we have sort of a full spectrum urology practice that offers everything and anything that a patient within the community, the listening audience, the Berkshire community would need, and would not have to really go out of the area to get those services. We have a phenomenal office staff. The support staff, the leadership of the office administrators, very welcoming, and we're ready to, take on the new patients. And
we finally have a full complement for urology.
We have them, so everyone's now welcome.
Yeah, that's great. So let's focus on female urology to start, if that's okay.
Sure, yeah, I'd love to.
I do general medicine. I would say the majority of my practice are women. And continence issues are incredibly common. So let's start with that. There's actually, you gave me ahead of time a very nice slide. It's slide 12, talks about the prevalence of female urinary incontinence. There we go. So, obviously that just shows that it's an incredibly common condition. A little more common as women get older. I was very interested to see that it drops off again as women age. Why is that?
Yeah, so that's it's an interesting observation for sure, and is there. So I think, what the science tells us in studying this and having practiced within that space for almost a decade and a half, is that overall female urology issues, continence, bladder control issues, frequency, is underreported across the board, not just here in the States, but worldwide, because patients are embarrassed. They don't want to really disclose that as an issue. And
I think a lot of women just feel like it's normal.
And that
and
adds
they don't
to
think
the
it's something that could be fixed.
Correct. And well, now, you actually come to the department, we'll be able to help. No, you don't have to really live with that, because we have, really, if you're going to have a problem with the bladder and urinary continence issues right now, this is the time to actually bring it to the attention of a provider, because we have so many options now, and we'll talk a little bit about that. But to your point, the fact that this seems to drop off at sort of older is because no one really is talking about it then. They're not really reporting it, and patients are either, at a skilled nursing facility where they just met, so they're not really in the pool of people who are now being newly diagnosed that sort of drives that trend up.
So the graph shows basically a reporting error.
Correct, it is, yes.
Yeah.
But it's a persistent condition that doesn't really drop off.
Right, I wouldn't think so.
No.
So now there are several different kinds of urinary incontinence in women. So let's talk about the different kinds. Slide 13 has a really nice picture for that with the different types of urinary incontinence. That's slide 11.
There we go. Yep. Yes. So this is a great slide. I chose this because anyone in the listening audience can sort of see it. It's pretty plain to see. But if we start off on the right, that box there, we have at least 5 different types of incontinence, as we can see. The most common incontinence that incontinence diagnosis that I see the patients for is the one up on the right upper corner, that urge incontinence. So this here is mainly a bladder nerve dysfunctional issue. It's usually the signaling between the nerve, the muscles of the bladder, and the brain that tells the brain that the bladder always needs to basically contract, like a spasm, whether the bladder is full or not full. So patients will say, I feel the urge, I get that desire, and as soon as I even feel it, I can't even make it to the bathroom, right? So that's that urge incontinence. Then we have stress incontinence, which is the second most common, and that is a lot of times due to some anatomic change. So whether it be someone having a surgery for hysterectomy or some pelvic surgery, whether it be colon, then you might have stress incontinence. And the way that works is if there is pressure increased within the abdominal cavity and over the pelvis, then stress. That's what it is. It's not stress like stress, overall stress, but stress, physical stress.
Right, like a cough or a sneeze
so with
makes you
coughing,
leak,
sneezing, physical activity, jumping, exercise, then patients say, well, I'm leaking and I have to, I have to wear a pad, or I'm changing the pad X many times a day. Then we go on to the functional incontinence. A lot of that has to do with patients who might have had a stroke or just don't have any real intact sensation, spinal cord injury, then that's what is under the definition of functional incontinence. And overflow incontinence is just like it says, it's where the bladder fills up to a point where the pressure in the bladder exceeds that of what the sphincter, meaning that sort of rubber band that keeps the urine from leaking, the pressure builds up in the bladder and it overwhelms that sphincter muscle, and the urine basically leaks through. So that's the overflow incontinence. And mixed incontinence could be a combination of any one of those 4, but the most common mixed incontinence we see is the stress with urge incontinence.
So each of those really has a very different cause. So presumably the treatment is very different.
Yes.
So the first step always is going to be distinguishing exactly why there's incontinence. And I imagine that's not always completely clear.
No, right.
Especially, sometimes to the patient, they know, oh, I can't make it to the bathroom in time.
Yes.
But it takes some careful questioning to tease out exactly which type it is. Is there a test that you have to do to determine which type it is?
Yeah, I think we have a slide, and we can actually walk through that. There we go. So I thought I'd include this because this is, I got this off the web, but it's it basically encapsulates what I, go through, or any one of my colleagues at the office would go through in sort of trying to delineate, like you said, Rebecca, whether it's one or the other. So we go through the usual down to where the green boxes sort of separate those 3 types of incontinences, for example. And to answer the question of, well, are there special tests and so on? Yes. I always go through what's called sort of a structured protocol as I counsel the patients, I present to them, well, look, these are the things I'm concerned about, and the only way for us to sort of discover, what they may be, we have to go through specialized testing. One of those tests is, of course, we send the urine, make sure no infection, things like that. We check for blood, because if there is blood in the urine, then that takes us off another path in a way, temporarily a lot of the times, but we have to at least make sure there are no major issues there. But getting back to the urinary control incontinence part, we typically would ask for an ultrasound if one was not done, just to check the bladder, check the pelvis, make sure there's nothing in the bladder or on the bladder, pressing the bladder. We sometimes check the kidneys, so all diagnostic. I ask the patient to consider a cystoscopy. Cystoscopy is where you use a camera to look in the bladder and check, make sure that there are no hidden tumors or polyps or stones, things like that. So a visual anatomic survey of the bladder, because we're talking about the bladder in terms of the urinary, control component. At that time, I usually do a full pelvic exam, so you speculum, we have special lighting, and I check the integrity of the support, of the pelvic musculature. I check to see if there is any point tenderness for pain that's induced on exam, because a lot of these things, if it's an inflammatory process causing or inducing some of the leakage, we need to know. And it's quick. None of this takes long. It takes about 3 to 5 minutes for me to do that. It sounds like a lot, but it really gives a lot of information within that short period of time. And there is a high-level test that I recommend they get that's called a Aerodynamic Test. And that test, I describe it to the patients as somewhat like an EKG for the bladder in a way, right? Because just like EKG for the heart, it assesses the strength and integrity of the heart muscle, the electricity and the electrical impulses going through the heart. Well, the same thing for the bladder with this Aerodynamic test. And we artificially fill up the bladder with water or saline to mimic what happens throughout the day.
So you're testing how much the bladder can
hold,
how much it can hold comfortably,
correct,
whether it can empty completely,
correct, yes,
right, the elasticity, the contractility. So you get a lot of information from that test.
You've earned your urology hat. You don't need me. But it's exactly so. Right. So when they come back and I give them the analysis of the report, those are exactly the components in terms of bladder function. I call it the 3 C's: capacity, contractility, compliance. That's the elasticity question. So that's the 3 C's in terms of bladder function. And then there's that fourth part, which is the EMGs, the muscle nerve study, that is part of this urodynamic test that tells us how is the bladder and all these 3 aspects of its function coordinated with the nerve signaling to the brain. Right.
So let's do a little comparison and contrast of urge versus stress in terms of the treatment options. Mm-hmm. Mm-hmm. So why don't we start with stress incontinence? Yeah, so again, that's the cough or sneeze leaking.
Yes. Yeah. So that one is pretty straightforward. If on the urodynamic test, and sometimes I do a crude stress test after cystoscopy, I fill the bladder up, I have the patient stand, they cough, and if I see leak, then okay, it's obvious, there's no question there. But I still do the urodynamic to assess how severe, how weak the sphincter might be, because that determines how, if we are going to do a procedure, how tense I might want to do a hammock underneath the urethra. All right. So for stress incontinence, it's usually the fix, or at least the intervention that's recommended, is surgery, because medicine does not really fix the anatomy. That's usually an anatomic defect, meaning weakness of the muscle that keeps the urine from leaking, and it might happen for different reasons. So a sling procedure is what it's called. It's like a hammock. I don't have a picture of that, but imagine that the urethra comes out. This goes underneath the urethra to sort of give a little extra support to reinforce the muscle, the sphincter, so that the urine does not leak when there is a stress action, sort of a cough or a sneeze. So that type of procedure is done in the operating room, usually outpatient. Takes me about half an hour to do a procedure like that, as long as the patient's anatomy is conducive to relatively easy approach. There are different kinds of sling. I've been moving more and more towards the single incision sling, which is done just in the vagina, and it's attached basically to the symphysis pubis is the bones that make up part of the pelvis. There are attachments, there are ligaments and fascia that allows the sling to hold to this tough fibrous tissue that gives the support. But there are other ways too. We can do it transobturated, which is small incisions made along the inner thigh. We can do a suprapubic, where you go from the top down, retropubic approach,
So we've got a conversation of a surgeon with an internist
Yes.
here. So, I mean, clearly there are excellent surgical options.
Yes.
How about for that, the woman who maybe has more mild symptoms, we're not quite to the point of surgery. You know, we have a couple of physical therapists in the area who do pelvic floor physical therapy. Is that something that can correct this?
Absolutely. So in my practice, as I've evolved, you know, over the last decade and a half of practicing, I've incorporated more and more of sort of an integrative approach to managing, especially this part with my female patients. And I work hand in hand back in New York with the physical therapists, with acupuncturists and massage therapists. And what that involves is in tandem working with me as the medical person, but also on the other lane, you know, working with these alternative approaches. So I do refer my patients to pelvic floor physiotherapists that are trained specifically in pelvic floor medicine. And they teach. So patients say, but doc, I do Kegels and I've been doing it for ages. You know, I had 3 kids. They tell me, I do Kegels and it's never worked. You know, why am I doing it? So a lot of times, are you exercising the right muscles? Do you know you're exercising the right muscles or the wrong muscles? You know, so those are kind of things. And with the physical therapy, they sort of get focused, structured instructions, really, along with biofeedback, meaning using the body to try and heal itself, to your point, but also making the patient even more in tune with what's supposed to happen versus what is happening.
And it's the idea that if the pelvic floor muscles have weakened, exercising them could maybe make them stronger, lift everything up.
Yes.
How about a role of vaginal estrogen or something like that?
So there's a caveat to the point you just made. So there are a lot of patients who, as you say, well, physical therapy, yes, it's thought, you know, we can do that, maybe. But if the patient is postmenopause, older, then the getting that muscle tone back, and if they had multiple kids, you know, large deliveries or hard deliveries, you know, had episiotomies, you know, things that just disrupted the anatomy, then it will be very hard for them to even, no matter how many years, decades they've been doing exercise, for them to really get that tension tone back. So then sometimes we really have to just move towards corrective surgery.
Right, and like you said before, there are many surgical options, which is really, which is great.
They exist, and risk level is moderate, and I explain that to the patient. But in terms of the adjunctive interventions, if it's safe, I do recommend that my patients, after I do my pelvic exam and I do my cystoscopy, I do assessment of sort of the vaginal area and the pelvic tissues and so on. I do say, well, look, you may be a candidate for some topical estrogen, not oral, not injective, because patients worry, well, breast cancer, ovarian, you know, and I do tell them, well, do you have family history? You know, what are your risks? Try to identify that. And if they're a candidate, I do actually propose that they do that, because even if we do end up doing surgery down the road, having that in the system locally helps those patients actually heal much better, and they take up, you know, whatever graft, or there are ways that I do this, you know, using graft, using various things to help augment the support that some estrogen. I sometimes, and this is anecdotal, I the vitamin E, if they don't want to use an estrogen, you know, I say vitamin E also, oil or cream, you know, because it's sort of the neogenesis process of these agents. That's really what brings to enhance nourishment and blood flow and oxygenation of the tissue that's been somewhat deficient, you know, for some time.
One other detail that I think is worth bringing up, it's something that's all over the medical literature, but not something we talk about so much with our patients, is how weight impacts stress incontinence. And a lot of my patients have found that if they can lose some weight, their incontinence actually gets much better. So I just figured that point was worth mentioning.
Yes, yes. And I actually tell my patients, based on, I look at the BMI, say, look, I'm not going to recommend any, even though surgery is what you may need, based on what I'm seeing here on these reports, I'm not going to actually do that.
Well, you want them to be successful.
Yeah, and then I tell them, I don't want you to come back in a few months and say, and sometimes it happens, I tell them, it's not foolproof, it's not 100%. All surgery has risks, has failure rates. But to increase the durability, and it working in you, there are certain things you can take on the patient side, that might help that. So
let's move on to urge incontinence.
Yes.
Completely different.
Very
There's
much.
no surgery for
yeah.
urge incontinence.
Yes. No.
So how would you manage that?
Actually, there is it's not a surgery so much, but it's a procedure,
Okay.
and we'll get to that. But
Yeah.
I'll walk through, same thing, for the listening audience, but for our discussion. This is fun, a lot of fun for me. But I'll walk through in a similar fashion. We do the workup, we do the testing, the baseline stuff I need, sort of data. And those are the tests we talked about. Everyone gets that. Urge, stress, functional, doesn't matter. They get that baseline evaluation. And then we get the treatment options. For the urge incontinence, I right away, tell them, even at their initial visit, I say, okay, you're drinking 3 cups of coffee a day. You're, drinking iced tea, in the evenings. There are various things that I try to identify. You like spicy foods, so those are the dietary and behavioral components of things that could potentially compound urgency and urge incontinence, right?
So caffeine is a bladder irritant.
It
so
is.
if you're having urge incontinence, cut back.
Yes.
Alcohol is another.
Yes.
Nicotine is another.
Yes. Yes.
And artificial sweeteners.
Yes.
Right?
Yes.
So
Correct.
I also have a lot of patients who say, well, I have to go all the time, and so I try not to drink too much because then I have to go more. But of course, the concentrated urine is even more
There you
irritating
go.
to the bladder.
There,
so
yes.
there's some behavior modification that could help.
Yes, and that is the top of my recommendation to patients. Come back in 6 weeks or a couple months. Let me know how you're doing. Bring your voiding diary. It says it all there on that, little cheat sheet. I hope the listener is probably writing some of this down. But yeah, you bring your voiding diary. Let me know how you're doing, how much caffeine you've cut back, right? How you're doing dietary-wise. And then we'll make some adjustments. And if things are still suboptimal in terms of where you are, then we can talk about medications, right? There are pharmacologic interventions that we could then employ. And, it's really exciting in the space of female urology overactive bladder now, because, you see all the ads about these new medications and the women, running around, the little thing. So all of that, now we have a lot of different pills, that we can offer. A lot of patients don't like pills, but I tell them, look, it's an option. It's on the table. We can consider. These are the side effects. The older medications are called Anticholinergic Medications. And what just like they sound, they're like antispasmodic agents for the bladder. So it calms down the activity of the bladder muscle. Remember what I said at the top, that it's a nerve, sort of hyperactivity to the nerve, and then the bladder muscle behaves that way, hyperactive. So this medication, muscarinic, anticholinergic agents, calm the activity of the muscle down. It sort of gives the bladder the ability to hold more urine more smoothly, more compliance, more elasticity to hold the urine without having as much of the urge sensation to go. So that's one of the things with that is you can have constipation, you can have dry mouth, some patients have headaches, so there are some downsides.
Right,
to
depends
that.
on the tolerability of the medication.
It does, yeah. So we dose titrate and so on, see how patients do, starting at the lowest and then going up from there. Now there's this newer class of medications that are they're alpha agonists medications, and they work on the bladder as well, but in a different way and don't cause the same spectrum of side effects in terms of dry mouth and constipation. So that's really my go-to as my preferred agent to recommend patient try if the insurance covers it. I've seen that patients actually have pretty good success and response with these newer agents, but sometimes we just don't have the option to use them. Denied by the insurance, we have to go to the older agents. There are some other ways that I approach the urge incontinence, in that if the patient is saying, well, I've cut down on my fluid intake, that actually is the opposite of what they want to do. And it puts them at risk for other things, kidney stones and uremia and things like that, that actually causes more irritation to the bladder.
Right. Drink more water so the urine is more dilute. So it's less irritating.
Yes. So that's sort of now the last thing, talking about the procedure, somewhat surgery, is that for refractory urgency urination symptoms or overactive bladder symptoms, there is this intravesical Botox concept. And it is FDA approved. Patients here, when I mention it to them, Botox, they're like, Botox?
Right, for wrinkles?
Yeah, you mean my bladder's going to look like it's 19 again? So I said, I don't know. But this intravesical, the data supports it. And I highly recommend it for the patients who have suffered through this problem for so long, have tried all kind of different medications, have modified their lifestyle, sort of done all the things that I say, look, try and do these things, or try this, as a medication. They get to this point where we have to think of this intravesical Botox. So it's for me, in my hands, it takes about 10 minutes. I like to do it under some sedation, but it can be done in the office on the local.
And if someone has a mixed incontinence, so they have some component of stress, would the Botox make that worse?
No, actually.
Okay.
I always, with patients with mixed incontinence, I always try to treat the urge aspect of it first, because about 30-40% of patients who actually have improvement in the urge find that their stress incontinence also improves. So that's a lot of patients who we may be talking about surgery, and then they actually don't need it, right? So I always, I say, look, take a few months, try the medication, see how you do, come back. And I've seen it in my own practice that a lot of patients come back improved sufficiently that they feel that even if we were talking about surgery, they would not proceed with that.
Okay.
Yeah. So the Botox is pretty straightforward. It's done in an ambulatory surgery center. It takes about 10 minutes with a little bit of sedation, and it's just injections in the bladder of this agent. It doesn't work right away, but usually at about 2 weeks or so, it starts kicking in, and it basically desensitizes the nerve endings to the bladder that sends the messaging again to those pelvic nerves in the pelvis, to the spinal cord, to the brain.
And is that something that would need to be repeated then?
Excellent. So it's not a cure, I
Right.
tell my patients. I have patients back in the city that I treat, and some of them don't. It's a small fraction of those patients, but some of them for a year they have good durability of the effect of the Botox. They don't feel they need anything. Well, I follow them. Every 4-6 months or so we check in. But most patients are coming back around the 6-month mark for a retreatment.
Okay, so twice a year, simple office procedure, and
but
then you don't need medication.
Right, so most
Right.
patients don't actually need to try to do these pills that's causing side effects, number one, or they just are not getting any benefit from it, but they continue to take it, hoping maybe if we add another one, or we change it, or we increase the dose, they'll have some improvement. So and I just want to add one more thing to that. So it's a really full complement of various options as we go through the urge, because urge is really the most predominant one that we see most commonly prevalent. There is something called pretibial nerve stimulation. So again, using the nerves as the back door to getting into controlling the bladder muscle, right? We can do it through medication, we can do it through Botox, but we can also do it through this neurostimulatory aspect, and
I always find it very curious that you can stimulate a nerve by the ankle and it helps relieve
Correct.
bladder spasm.
Yeah.
How does that work anatomically?
Right. It's all about the anatomy back when we were back in medical school and the anatomy. So there's this pretibial nerve that comes off, the inner part of the pelvis and goes down the leg and ends up just around the ankle. But it ties back into this node, in the pelvis that then goes back into the spinal cord, and a branch from that actually goes to the bladder. Those are all pelvic nerves, and by retraining those nerves and sort of decreasing the activity, from here, it's actually like a little remote. The patients have in their hands. They sit on a nice recliner, chair. They have their feet up, and it's like an acupuncture needle. It's very small, like a wire, really. It doesn't hurt. And you actually put it right next to the nerve, and you can, when the technicians are actually doing it, you know that you are close to the nerve or far from the nerve, because you get the signaling in this little connection that goes to the remote. And then the patient sits for half an hour to an hour, and there's a plus-minus button, and they can actually modulate, the intensity, and they actually can feel what's going on in the pelvis and around the bladder and around those muscles.
So they're able to control the intensity by saying, "Oh no, that's enough.
Too much." Right? Yes, right. Exactly. And
for comfort.
Yeah. And it's FDA approved for overactive bladder symptoms, urinary frequency, urgency. Usually, it's 12 sessions is what's recommended.
How frequently?
It's once a week, for 12 weeks typically. And after the 12 weeks, what we look for is at least between a 30 to 50% reduction in symptoms.
So not perfect, but better.
But better. It's all about, because all of this is a quality of life issues for patients, and they just want to get to a threshold where they can actually have some semblance of normalcy to their quality of life, So a lot of times they don't need complete resolution of the problem. They just need some improvement enough that they can get back into enjoying life and not being controlled by their bladder,
Right. We just have to make sure patients' expectations line up with the expected results.
Yes. Yeah.
Right.
And that's I think there are some other little things, but that's sort of the big ones for the incontinence and urgency of urination part.
So we actually only have a few minutes left.
Wow, already? That was quick.
I want to take advantage of your female urology training, because we were going to talk a little bit about the gender differences with regard to bladder cancer. So I was hoping you could talk for just a few minutes about the difference between men and women with regard to bladder cancer and the workup for blood in the urine.
Yeah, good. So we did touch on this a little bit, and that's where I was going, that sometimes we have to divert the path of care for a patient if we discover something along the line that we really don't know, why is this happening? And one of them is blood in the urine. Hematuria is the clinical term we use, but blood in the urine is one of the most common condition we manage or evaluate as a urologist. And there are different reasons that blood in the urine can happen. It could be kidney stones. It could be some benign condition, like a tumor, infection, inflammatory, things like that. Or it could be malignancy. And those are the things that we worry about the most. With blood in the urine, 80-85% of the time it's not going to be anything bad, but we're hedging against the 15-20% of what could be potential malignancy. So with bladder cancer is one of the more common ones. Risk factors include tobacco, smoking, nicotine, occupational exposure such as smoke, tire, so road workers, who breathe a lot of the tar, so aniline dyes, things like that. Benzene, all of those are occupational exposure risks. And with men, even though most of the cancers are diagnosed, about 15,000, cases would be men out of the 20,000 or so cases that we might diagnose in a year. About 5,500 would be women.
So much more common. Three times as many cases in men compared to women.
But and I've done some of this work at Columbia, some of the research, looking at the presentation. So at diagnosis, what we find overall in all comers, with bladder cancer, once we've diagnosed it, women tend to present with more advanced stage at diagnosis. It might be more extensive in the bladder if it's still localized, or if it's now progressed beyond the walls of the bladder, be more extensive in the pelvis.
And could that be because they're not reporting their incontinence to their doctors,
So,
or is there something else going on?
Right. So one of the issues might be that, the symptom of urination that they may have experienced or were experiencing was a prelude to something else going on, never got it checked out, yes. But we theorized on one of those studies that it might be something with we don't know, but we theorized that it might be the blood flow pattern, in the pelvis. That you have the gynecologic organs, you have, it's somewhat different between men and women in terms of how the lymphatics and the blood flow is there.
So they're
and
anatomic explanations.
It might be, and that's
right.
that's what we were going on, at least, with these initial studies we were doing at Columbia.
Right.
But yeah, there are other behavioral things too. We know that men with tobacco and smoking and sort of some of the work that they may do, there might be an increase. It's all about at the time of presentation. Why is it that women tend to be at a more advanced stage? It just be because it's probably delayed in being caught, as well. So
anyone with blood in the urine is going to need a cystoscopy then to make sure that there's nothing actually growing in the bladder.
Yeah,
even though most of the time it turns out to be
it'd
fine.
Be fine, yeah. So patients get really anxious when I say, "Well, you need a cystoscopy," and I understand because it's not like they get a cystoscopy every day. We do this day in, day out, multiple times a day.
It's no big deal for you.
No, it's an easy thing to say, get a cystoscopy. But yes, it's a highly recommended test when we see blood, whether it be microscopic patients, but I don't see blood in the urine. What do you mean I should get this test? You're putting things in my bladder and I don't even feel anything or see anything. Well, it's there under the microscope and we see it 1, 2, 3 times. Then it's pretty convincing it's not going away. A lot of times it's just kidney. It could be blood pressure related. It could be diabetes. Exercise. Strenuous exercise can induce hematuria or hemoglobinuria. So there are different things, but our obligation is that if it's consistently positive with blood in the urine, a one-time, fine, we'll check you for infection, but we check it again and we check it again, and we tell you, look, it's positive,
so
then
it's really
you should.
If it's persistent, then
yes.
you do the test.
Yeah.
Okay,
And gross hematuria is different. That's where you actually see the blood in the urine. You urinate and it's red in the toilet, then there's no question that you should get a cystoscopy.
And my
It's right
patients
off the
don't
top.
delay care when that's the case. It's
they're
terrifying.
right, because it is scary. One drop of blood looks like you're
Right, you fill the
exsanguinating.
bowl,
Yeah.
right.
So it's very scary. But yes, we don't take hematuria, that is microscopic hematuria, lightly if it's persistent, and gross hematuria needs to be worked up relatively urgently.
Yeah. Okay, well,
Or semi-urgent.
thank you very much for coming. We're actually out of time.
Wow.
We didn't even get to the prostate. I'll have to have you come back so we can address the prostate.
Would love to. This was a lot of fun.
So this is Dr. Jason Ogiste. Thank you, joining Berkshire faculty in the Department of Urology. I'm Dr. Rebecca Caine. You've been watching Berkshire Health Programs. Thank you, and I'll see you next time.